Our topic for the May MEC Minute is going to be Heads Up CPR. And during this conversation, we're going to discuss our new Heads Up CPR protocol, which goes into effect July 1st. So we're going to review the protocol. You're going to see the training video as part of this minute today. And we're going to need to start conversations about how we train and get ready for this program come July 1st. We're also going to review updates to our CPR and termination resuscitation protocol as part of this discussion. And we're going to also, toward the end of the conversation, after we go through Heads Up CPR, we're going to review some procedural changes to our protocol that we're making mid-year, and these are unrelated to Heads Up CPR, but important that we accomplish. And we'll talk about that toward the end of the discussion. So why Heads Up? Well, studies suggest that cardiac arrest patients are more likely to survive the hospital discharge with Heads Up CPR. It's unclear at this time if it's the head elevation that makes a difference or if it's the entire process. So the process is not just bumping the head up. It has to do with good compressions. It has to do with elevation of the head. It has to do a lot with practice. It also has to do with adding rescue pod or ITD in as part of our airway procedures. So there are multiple things that go into this process. So what kind of changes are we looking at? Well, first off, the Heads Up CPR program is only for adult patients who are suffering cardiac arrest unrelated to trauma. The protocol does not apply to patients under ages 18. It does not apply to patients who are in cardiac arrest because of trauma. For the patients to be part of the Heads Up protocol, they have to fit the Lucas. So if the patient's too big, too small for the Lucas device, they are not a candidate for Heads Up. And that's because as part of the Heads Up process, we have to have Lucas on and running because it's the only effective way to give good compressions with the patient's head elevated. We are going to place a PT wedge under the patient's trunk to elevate the head and the trunk. We're going to do that 2 to 4 minutes after a crew arrives and start CPR. Also, a start of our change to our process is all defibrillation shocks will be at 360 joules if we're using the Physio or Medtronic Stryker device, or 200 joules for Zoll. So we're not going to do stacked shocks anymore. It's going to be 360, 360, 360. If we have a patient who is in refractory VT or VF, meaning they are fibrillating, and we've shocked them, we're going to change our pad placement from the standard left lateral and right anterior to anterior posterior. So we're going to do 3 standard shocks in the standard position or pad placement, and after the 3rd shock, we're going to transition to anterior posterior. So as part of our Heads Up process, if the patient's rhythm on arrival is VT or VF, we will place the posterior pad necessary for anterior posterior shocks, and I'll show you a diagram of that. But that has to be rehearsed so that when we lift the head to put the wedge underneath, somebody has to sneak that posterior pad in place, and it has to be put in the correct position. We've also made some adjustments in our termination resuscitation policy. Some of it has to do with formatting, but the biggest change is we're going from 20 minutes of resuscitative efforts before TOR to 30 minutes, and that's because data suggests that that extra 10 minutes may make a difference in patient outcome. Now, the termination of resuscitation or TOR policy will not apply in patients who have ROSC. So if the patient is in arrest, you get them back. We're going to package and transport. We're not going to wait for 30 minutes on the scene. Another exception would be if there is a patient still in VF or VT after their 5th shock, so that's 3 standard and 2 anterior posterior. If they're still fibrillating or still in refractory VT, we're going to transport at that point as well. We've also made some adjustments to TOR so that if there are extenuating circumstances, like it's an unsafe scene, we don't expect you to stay on scene for 30 minutes. You can package and move the patient. Also, for certain other circumstances, such as the patient is a hypothermic arrest or it's a pregnant patient in the second half of her pregnancy and she is in cardiac arrest, those patients we're going to initiate cardiac resuscitation and transport immediately. The vast majority of our patients are adult, non-pregnant patients who are in asystole or PEA arrest. Those are the patients we're going to work on scene for 30 minutes, unless there are extenuating circumstances like scene safety. So what does this heads-up process involve? Well, first off, you have to practice this. You have to practice the dance. You have to be comfortable doing this. Your crew members need to know what their position is, what their role is, and how we get this in place. It's not something that you just take the wedge off the truck and you throw it behind the patient and everything's hunky-dory. You have to practice this. We're going to provide high-quality CPR from onset, and we're going to defibrillate early. So our initial priorities do not change. Scene safety first, then we're going to get on the chest and do CPR, and we're going to defibrillate as soon as reasonably possible for those patients that require defibrillation. Scene stabilization has to be allowed to occur. So we do want to get this in process. We want to get the heads elevated within the first 2 to 4 minutes, but we also need to make sure we have adequate resources on scene. You're going to need 3 to 4 people to do this and do it well. So if you have a 2-man medic show up first, their priorities are good quality compressions and CPR, and defibrillation. As additional resources arrive, that's where we're going to get the wedge in place, get the Lucas up and running, and get this wedge under the patient. We've developed a process where we can insert the wedge in the Lucas backplate and a TARP or mega mover quickly as one maneuver. We learned how to do this as part of 4 trials we did across our various agencies in April, and we made substantial improvement with practice in our implementation time. We went from about 30 seconds to about 10 seconds just by reviewing process and modifying our procedure. As part of this insertion, as we lift the patient to place the Lucas and the Lucas backplate and the wedge and the mega mover, we're going to place that posterior defibrillation pad if it's indicated. And the indication for the posterior pad is if the patient's in a shockable rhythm on EMS arrival. We are going to ventilate the patient, probably use a BVM, but we're not going to worry about advanced airway until after the wedge is in place. You'll also find that once the wedge is in place, the head is elevated, it's easier to insert an airway. It's easier to get a good view if you're going to intubate. It's easier to get the iGel in or the supraglottic device in. It's just easier to do when that head is elevated on the wedge. Keep in mind when you place the wedge under the patient, the occiput or back of the head needs to rest on the top of the wedge. We don't want the head and the neck hyperextended with the head flopping back behind the wedge. So we need to make sure with wedge placement that back of the head, the occipital area of the head, is resting on the top of the wedge. So what does the process involve? Well, we need a physical therapy wedge. We've identified these online. They're about $50. It doesn't matter what color they are. You pick a color that matches your decor. You're going to need defibrillation pads. You're going to need at least 1 set for your standard setup. You may need 2 sets of pads if the patient has a shockable rhythm. You're going to need a Lucas. So we need this Lucas as part of the process, and it is important. One thing I want to point out is if you look at this diagram, you can see the straps for the neck strap, or the pinch points, the holding points for the Lucas neck strap, are down low. We found that in order for this to work, the neck strap needs to be attached up high near the motor and piston, otherwise the Lucas is going to tilt. You're going to need a TARP or mega mover. That's inserted under part of the process. That's so that if the patient is going to be transported, you don't have to then start moving things around in order to get the patient moved. And then finally, you're going to need a rescue pod. This is a device that goes in line with the BVM and CO2 detector. If you look at order of application, it should be your mask or airway device, whether it's an iGel or a tracheal tube, then your CO2 detector, then the rescue pod, then the bag. If you look at the rescue pod in this diagram, there's a little blue button at the top. You turn that on. What that does is there's a LED light that flashes every 6 seconds, and when that LED light flashes, that's when you bag the patient. So make sure you understand how to get these devices in line with the bag. Make sure you know how to turn the rescue pod on. How about pad placement for standard versus vector change? So the standard placement is what we currently do, and the vector changes, we're going to use pads placed anteriorly and posterior. So, we're going to talk in a moment about where those pads go. All shocks are going to be at 360 joules, again, 200 joules for Zoll devices. We're going to go standard pad placement as soon as you can practically do it for rhythm and shocking if indicated. After 3 shocks, we're going to go to 2 shocks with vector change, meaning anterior posterior pads. And for a patient who's still in VT, VF, we're going to transport after the 5th shock. We are going to use amiodarone as per our protocol. We're going to use epinephrine as per our protocol. And then for VT, VF patients who are in arrest, we're going to place the second set of pads with wedge placement. And you'll see how this is done when we do the video demonstration. Here's kind of what we've got as a layout. So on the left-hand side, you see standard pad placement. For all of our patients, you want to put that pectoral pad on the right side above the breast, and the left-sided pad kind of goes about the level of 6th rib laterally. You really want it between the midclavicular and the mid-axillary line, or even maybe a little more posterior. The second set of pads we're going to use, we're going to do anterior-posterior. If you have to add anterior-posterior, you leave the original pads on. You don't need to worry about taking them off. But we're going to put a second set of pads on. So if you take out your new set of pads, the pad that typically would go to the left lateral chest is going to go overlying the left breast to the left of the sternum and just above the first pad that you placed. You want to make sure that the pads do not touch, and you also want to make sure you don't put this pad over a pacemaker or AICD if it's present. You can put it near it, but you shouldn't put it directly over it. When you look at the video, I'm going to demonstrate placement, and you can tell I didn't do a lot of pre-planning. My pads touched a little bit, so that's not perfect. It needed to be better. If you look at the second pad, so the pad that you would normally place over the right chest, you're going to put that on the back. So you're going to put it to the left of the spine and just inside of the inner edge of the scapula. And you want the lower part of the pad to be at about the same level of the lower edge of the scapula or the scapular tip. So that's where the second pad goes. So you put these 2 pads in place. If you need to do vector change, you disconnect the first set of pads, you connect the new set of pads to your defibrillator, and that's what you use to shock the patient. If you give additional shocks after shock number 5 during transport, I would continue with the anterior-posterior. I wouldn't worry about switching back and forth between one and the other. If you look at my diagram on the right, at the top it says DSED, that's for double sequential defibrillation. We're not doing that because we don't have 2 devices on scene, but we're using this diagram to illustrate correct pad placement. So what happens if you do everything right and now you've got the patient heads up, you've got the patient recovered, you have ROSC? What do we do? So your patient is now post-arrest. Well, we're going to keep the head up. If we need to give pressors or fluids because the patient's a bit hypotensive, that's okay. So our preference is going to be to add an epinephrine drip rather than take the wedge down from below the patient. So we want to keep the wedge in place. We remove the rescue pod once we have ROSC. The rescue pod is only effective, only good when the patient is being resuscitated. Once we have ROSC, you take the rescue pod out, keep your capnography sensor in place, use your bag as you need to ventilate the patient. We've added to the post-resuscitation protocol ketamine as needed for sedation. We've also added ketamine to our CPR guidelines, to our cardiac arrest guidelines for patients who become aware during CPR. We have some patients who start to wake up with good quality compressions. We want those patients to be unaware of what's going on, so you can also give them some ketamine during resuscitation if they become aware. We have succinylcholine in our protocol for use as needed to protect lines and tubes. There's a comment here that I've added that no one is given succinylcholine without sedation. And we have been aware of a recent transport where a patient was intubated in a freestanding facility, was transported chemically paralyzed, did not get sedation at the request of the transferring physician. That is against really our practice. If the patient is chemically paralyzed with succinylcholine, vecuronium, rocuronium, they should be sedated. regardless of what others want. And so we really need to sedate patients as needed during transport. So now it's time for a series of videos that we recorded at Lancaster. It'll start with me talking a little bit about the scene setup, and then we'll do a scenario of a resuscitation, and then Rich Charles from Lancaster Fire will review what's done and give some helpful hints. All right, thank you for tuning in today. We are going to do a review of our Heads Up CPR program that goes into effect on July 1st. So I'm going to do a couple quick comments, and then the Lancaster crew is going to run through a scenario to demonstrate our process, and then finally Rich Charles, who's coordinated a lot of this training through Lancaster, will give us some ending comments and helpful tips. So a couple comments for me. First off, this Heads Up CPR program will start July 1st. So we're going to take the month of June to practice and trial. Practice is going to be important for everybody in order to get this process as smooth as possible. Concept's not hard, but implementation takes practice. One of the things we're going to talk about, or what we're going to do as part of the CPR process, is right now we have a mandatory 4 minutes of compressions done manually before we can transition to Lucas. We're going to dial that back to mandatory of 2 minutes, and then implement Lucas placement and heads up process as your manpower, as your staffing becomes available. So the primary focus still is good compressions and early defibrillation. The next step is going to be implementation of the Heads Up program when you have adequate resources on scene. The Lucas device is required, so if the patient is too big or too small for the Lucas, they're not a candidate for Heads Up CPR. They have to be on the Lucas in order to get effective compressions with the head elevated, utilizing the wedge that we've identified for use. We are also going to allow wedge use, but if you have the gurney at the side and you want to put the patient on the gurney and elevate the head of the gurney in order to elevate the head for compressions, you can do that as well. If you anticipate doing that often, then you really should practice this process not just with wedge placement, but with moving the patient to the gurney and putting the head of the gurney up to 30 degrees. I just want to show a couple pieces of equipment. As part of the process, we're going to use the rescue pod. What the rescue pod does is when you come off the chest, or when the Lucas is decompressing, it allows the chest to recoil, which increases the negative pressure in the chest. What the rescue pod does is it keeps that negative pressure from being lost through the endotracheal tube or the airway that's in place. So it makes that negative or that decompression phase more effective. It also comes with a switch on it, and you can turn it on and it will flash when ventilation is needed. So our focus should be on ventilating the patient when we see the red flash. So when the light's on, you squeeze. When it goes off, you let go. In terms of placement, we're going to have our airway, whether it's the mask with the BVM or an iGel or an endotracheal tube. That's going to be the first part. The next thing in line is going to be our CO2 sensor. The next thing after that will be the rescue pod. And the final part will be the BVM, or the bag. So this is how things are stacked as part of the resuscitation. We need to have CO2 readings so that we can evaluate for ROSC and evaluate effectiveness of compressions. Another thing that we're doing is if the patient has a shockable rhythm, VT, VF, and they do not respond to the first couple shocks, or the first shock, they stay in VT, VF, we are going to add a second set of pads as we transition to heads up. So if you look at our dummy here, we've got our typical pad placement. We've got the one on the right chest. We have the second one left lateral, about at the level of the 5th or 6th rib. If the patient is shocked and still fibrillating, and we are going to start a heads up, we are going to place a second set of pads as part of that process. So the pad that's supposed to go lateral still goes to the left side of the chest, except we're going to put it over the left pectoral area. You want to make sure the pads don't touch. That wasn't a good job of placement, but you want to make sure the pads don't touch. When the body is elevated to put the wedge underneath, somebody needs to take the second pad, the pad that should traditionally go to the right chest. You take this pad and you slap it on the back when the patient's up. And you want it to be between the spine and the lower scapula or shoulder blade. Because if after 3 shocks the patient's still fibrillating, we're going to transition to using the second set of pads, the anterior-posterior pads, for all future shocks. So it's going to be 3 standard shocks, patient still in VF or VT, we're going to use the second set of pads. So as part of our handout, you will see some graphic placement of where those go. We also need to encourage everybody to keep practicing, because this is a transition. And as I mentioned, Rich is going to give you some helpful tips in terms of transitioning. I'd also like to take this opportunity to thank everybody that's involved in this project. We've had 4 different training sessions and practice sessions in April at 4 different stations. We've had a lot of turnout and support, and now it's time to thank everybody who's been involved. I'd also like to thank you for assisting us in hopefully improving our patient cardiac arrest outcome.
Hi there.
Hi.
What's going on?
I was walking down the street and I found him on the ground.
Bryce, can you check for a pulse, please?
No pulse. We'll start CPR.
Ventilate.
Pete, when you get a second, that end title's under his arm. I'll get it.
Ventilate. Ventilate. Ventilate.
You connected to O2 and everything?
Ventilate.
Yep. Very good. Bryce, you're doing good. At 2 minutes, we're gonna check the rhythm.
Engine 1's here.
Ventilate.
What do you guys need?
Ventilate.
Carly, can you do the IO? Dean, can you get ready to switch out CPR?
Sure. How close are you to switching?
We're about 30 seconds out.
Okay. Battalion 1's here. What do you guys need? Can you get some patient information for us?
Ventilate.
Your patient information, talk to the family.
Ventilate.
IO's in.
Jake, you doing all right up there?
Pete, draw up.
Bryce, you doing okay with your impressions?
I'm gonna charge.
All right,
Monitor.
hang tight.
Good marrow drawback.
Ventilate. Ventilate.
Everybody clear? Good. Looks like we have fib. I'm gonna shock. Back on the chest, please. Carly, you got your epi drawn up?
Yep, I'm getting it right here right now.
Careful, I got the Lucas standing up beside you.
Epi's gone in.
You getting the
Epi's in.
wedge,
Wedge in
Bryce?
the back,
Okay.
Ventilate. Ventilate.
How far are we into the second cycle?
20 seconds.
All right, so at the 4-minute mark.
How are you doing up there, Jacob?
Good.
Alright. Your entitle's about 10 right now.
Get our wires
Ventilate.
over here adjusted.
Ventilate.
Bryce, at the next pause, I want you to put that wedge underneath of him, and then Carly, help Rich attach.
Mm-hmm.
Do you have ammo drawn up?
I do. I'm ready when you're ready.
Alright, I'll let you know.
Ventilate.
We got one epi in.
One epi.
Ventilate.
think you might move over to your right just a little bit, so Bryce, get that wedge in there good.
Ventilate. Ventilate.
Around a minute 30, is that right?
Yep. You want to go ahead and give the amio, you can go ahead and do that.
Okay.
Ventilate.
Cameo's in.
Charger.
Grab that for me.
When that's done charging, I'll do a rhythm check and the shock if need be.
Ventilate. Ventilate.
Stop compressions. Looks like we are still in fib. We're in shock. All right.
Patch it on.
Patch it on.
Watch those wires for me, please.
Ventilate.
Arm, please. Arm.
Next strap.
I think I got your second happy ready.
Step
Ventilate.
about 2 minutes away from that.
Ventilate.
Actually, we're about a minute away. No, so
Okay.
You got the patient demographics, history, meds, allergies.
All right, so let's go ahead and deploy the tarp.
Ventilate. Ventilate.
All right, go ahead. Whenever you guys are ready.
Yep.
1, 2, 3.
The Lucas will keep running, but it just shuts off because of the mannequin.
Ventilate.
all right, Epi's ready, Carly.
Okay. Happy's in.
Epi's in.
All right, good, thank you.
Hello, my name's Rich. I'm from Lancaster Fire, and our crew on Crew 3 at Lancaster here has been doing practice for the Heads Up CPR for about the last month and a half or 2 months, almost every shift. So Dr. Zeeb asked me to talk about some things that we've found that helps speed up the process and make it more efficient. That's what we've been working on a lot as we've been doing this practice. So I just wanted to go over some things that we found in the last couple of months. Probably the first thing is just know what your role is going to be ahead of time. Whether that be you decide what position, what role you're doing in your position at the start of your shift, if you're talking about it on the way to the call, either way, just when you walk into that call, you need to know what your role is going to be. The other thing is we've got a combination here of basics and basic EMTs and paramedics. And so we talked about, initially we thought maybe they're only going to be stuck doing compressions, but actually your basic EMTs can do your airway position. As you've seen in the video, that at some point we're going to have people freed up once we get the Lucas on. And so your medic then at that point can start preparing the airway equipment and then move into that position where they can do the intubation. And then even your basic EMT can also start ventilating again. You don't even have to keep your medic there at that point. The other thing is when we started training, we had a couple of kids just kind of makeshift together. We did it in a big open area, and it really wasn't realistic as far as space and the equipment that we have. So we changed it up a little bit. We took some kits we had empty here that was similar to exactly what we had on the trucks, and not put the equipment in it. We weren't worried about that. It was more for space, and so we added all the things that were going to take up space that we would have on a real call and use them to train with. And then we decreased the size of the space that we were training in also and performing the resuscitation. And so we were kind of getting a better idea of how much space we were going to have and what it was going to take. So what it taught us was that our unneeded equipment needs to be out of the way. So when you first get in and you are just going to bag, once you get that ambu bag and your oral airway and your rescue pod and Untitled, your airway kit can just kind of be out of the way. And so if you can do that, that'll help you with space. And these are just kind of in random order. So we'll just go through these. The other thing is, don't rush trying to get the wedge and the Lucas on in that first 2 minutes. Give it that 4 minutes. We've tried that a couple of times of getting it in there in that first 2 minute mark, and it's usually just real clumpy. It's not very efficient. It takes longer. Just take your time and get it there. Do good compressions ahead of time. Make sure that you're just taking your time to get the Lucas and the wedge on there efficiently. And as you practice it and you get better, you'll get that time down doing it at that time. So when you get the Lucas on, you're going to want to put the straps for them up in a higher position. The Lucas tends to want to fall forward since we've got the head elevated. And so it wants to fall forward and gets out of position a little bit. It kind of migrates the plate to want to go down. So you want to get the straps up high, but before you get those straps connected, you saw in the video that we held the Lucas in place, and that definitely helps keep it from migrating down. In the video that we had there, the mannequin just has a lot of resistance if we actually have it in the proper position, and that's why the Lucas stopped in the video. The other thing too, we found that if you can have a person kind of in an overwatch position, so that's what I was doing in the video. Usually that's going to be probably a good position for a good role for your lieutenant maybe on the engine, or whoever your second company is. Somebody from that position, they can do a couple of little tasks, but if they're there ready to lift that patient when you're ready to put them on the Lucas and the wedge, being in an overwatch position, because they see everything that's going on and what can be done efficiently and what can be done differently, while the guys on the ground are not necessarily seeing it. So that does help. We did find that. It's not good to necessarily just have them back doing nothing but part of that crew and being in that overwatch position is helpful. And so that person's role is going to be paying attention to downtime. You saw in the video, once we got to a point, there really wasn't a lot of things to do except wait for the next pause when we're getting the wedge and the Lucas on. So usually in the video it wasn't so much because things happened a lot faster. The IO and the medications got in a lot faster than probably what they were going to be in real life. But there's probably a task to be done, whether it be moving some equipment out of the way and getting it prepared for the wedge and that kind of stuff, so you're getting it in the right place. There's probably something to be done, and that's what that overwatch position should be doing. On our change of vector pads, if you're going to put that on, just make sure that third patch, the one that goes over the heart on the left chest, gets done prior to you're doing the lift, and then obviously that fourth patch as you're lifting. Somebody, usually the person with the monitor, can take care of putting that patch on the back at that point when they're lifting. We talked about training kits. The other thing I noticed a lot in our training was that the wires just kind of got laid across the patient's arm, plugged into the monitor, and when we lifted, they got in the way a lot. And sometimes they even pulled the patches off. So make sure those wires are, as they come across the chest, whichever side that may be, that they get underneath the patient's arm, so when you're grabbing that patient and lifting, however you lift them, it doesn't get caught. Same with the end-tidal tubing, it'll do the same thing. And then pre-attach your tarp. That's been a very big help for us. You may not ever get to happen to deploy the tarp if you get to the 30 minutes and nothing's changed and you call it, but whether you get ROSC, something else changes where you're going to do a transport, you have that tarp in place, you can deploy it. There's a certain way that you'll want to fold it to make sure that the handles that you pull are on the bottom. That makes it easier to deploy. But try to pre-attach that tarp to the wedge. That makes it a lot easier. And then as you practice, just problem solve. We did the same thing today, even as we've been practicing. We had a couple of issues before we did the video, and we were able to just say, okay, let's do this, and we fixed the problem before we got to doing the video. So every time you practice, you're going to find things, just problem solve, see what works best for you guys on how you run. This is how it worked good for us, and hopefully that helps and works well for you, and hopefully you guys can figure out some ways that'll be best for you. So thanks for tuning in.
All right, my thank you to the MEC Protocol and Education Committee for helping us work through this process. Specifically thanks to Matt Coriel, who's the chair of the P&E committee. I really would like to thank those who assisted us during our 4 April practice sessions. We learned a lot by doing this, a lot of good common sense ideas and comments about how to do things. My thanks also to the MEC EMS coordinators who've been involved in this process from the beginning. And my special thanks to Captain Claymeyer, Lancaster's EMS coordinator, Rich Charles, Lancaster paramedic, as well as those firefighters who are on duty at Lancaster Fire Department Station 1 when we recorded the video. One other thing I need from you as part of this rollout is please socialize and share our heads up protocol with non-MEC EMS mutual aid companies. You know, it's possible that we have a cardiac arrest and one of the companies on scene is not part of our protocol. From my perspective, it's always the paramedics providing patient care. It's their protocol that's in effect. So if we have a cardiac arrest and it's a MEC EMS paramedic on scene with a non-MEC engine company, then MEC's CPR protocols, cardiac resuscitation protocols apply. If it's a MEC engine company and a non-MEC paramedic crew, it's that medic's protocol that is in effect, not ours. So these are details that need to be worked out as part of our process. If we have non-MEC engine companies that want to assist with placing the wedge, they should have some idea how to do it, and we should have practiced this with them beforehand. I want to go through a couple other protocol changes that are being made as part of the rollout. I mentioned it already, but we've added ketamine at 0.3 milligrams per kilogram IV or IO for adults and children who show evidence of awareness during CPR. You know, if they start to wake up, medicate them. For adults and children, we've adjusted our maximum dose for fentanyl. Our current protocol is 1 microgram per kilogram per dose with a maximum of 100 micrograms per dose. We have changed that. There is now no maximum absolute number to the dose. It's going to be 1 microgram per kilogram per dose. If the patient's 130 kilograms, they can have 130 micrograms of fentanyl. Our total cumulative dose, so the most amount of fentanyl you can give a patient, is 4 micrograms per kilogram. So again, getting back to that 130 kilo person, they can have 4 doses of 1 microgram per kilogram. So that would be 4 doses of 130 micrograms per dose. So there's no max on each individual dose, but they can have no more than a total of 4 micrograms per kilogram. We've made some protocol formatting changes to the adult and pediatric behavioral emergency and pain protocols. I'll show them on the next slides. My thanks to Lieutenant Hussey from Granville. He worked with Gordon Griggs at ResponseSoft. I think these algorithms are much clearer. And finally, the last significant change to our protocol has to do with pediatric intubation. Upon input from Dr. Stoner, we now use cuffed endotracheal tubes for all ages. We no longer use uncuffed tubes for pediatric intubations. So looking at those formatting changes to the algorithms, here is what the adult pain control algorithm looks like. It's basically, pick your drug, fentanyl first or ketamine first. It goes through the doses and routes of administration, and again shows that there's a maximum total dose of fentanyl of 4 micrograms per kilogram, IV, IO, or IN. And we still can give ketamine at 0.3 milligrams per kilogram for pain that's uncontrolled or not adequately controlled by fentanyl. So no content change, it's a format change. Same thing for our behavioral. We have made it much clearer. Again, there are no significant dosing changes. It's all formatting. And we've also added that if the patient continues to have a behavioral emergency, has not responded to the first dose of medication, you can repeat a dose of the original medication, but half the dose. So if the patient is a SAT of +3, you gave them ketamine at 4 milligrams per kilogram, and they're still quite agitated 10 minutes later, you give them the same medication but half the dose. We're not going to mix medications. Either they get Versed or they get ketamine. Where people get into trouble with respiratory depression is when we give both. So pick your poison. It's going to be either midazolam or it's going to be ketamine. once you make that choice, that's what the patient's going to get. So that's really the end of the discussion. Please discuss the new protocol changes with your EMS coordinator. Practice, practice, practice. Heads up has to be practiced. You have to have the equipment out. You have to be down on the floor practicing it on a mannequin or one of your coworkers. If you have any questions, also please post them on Basecamp. And as usual, you can also send them to me via my MEC email. I greatly appreciate your participation in this project. Thank you for your time. Again, if you have any questions, talk with your crew members, talk to your EMS coordinator, post a question on Basecamp, or send me an email. Thank you.